Neonatal reflexes, also known as immature or primitive reflex, it disappears sometime after birth. Reflex first is palmar grasp, involuntary palmar grasp at 28 weeks of gestation, fully developed by 32 weeks of gestation, stays for 2 to 3 months. Second is rooting reflex, helps in initiation of feeding. Stimulus near mouth, face turns ipsilaterally. 28 to 32 weeks of gestation and stays still 34 to 36 weeks of gestation, less prominent after 1 month. Moro's reflex, holding the baby up, extension and abduction of hands, sudden dropping, flexion and adduction. Starts the 28 to 32 weeks and goes away by 37 weeks, stays still 5 to 6 months. Asymmetric tonic neck reflex, neck turned towards one side, ipsilateral extension, contralateral flexion. 35 weeks of gestation. It's seen 1 month after it goes away, fully developed at 1 month after birth, and it stays still 6 to 7 months. Rooting reflex helps baby to find and latch on a nipple during breastfeeding. Moro reflex abnormalities. Abnormal Moro reflex. So your Moro reflex is this one: sudden dropping, flexion and adduction. So it's absent response in term babies is due to structural functional disorders in the brain, causes brain anomalies, for example anencephaly, decreased brain function like hypoxic ischemic enchephalopathy, can be seen as babies preterm, like less than equal to 28 weeks of delivery. Sluggish response, that is due to hypotonia. It could be due to metabolic disorder, Down syndrome, spinomuscular atrophy, etc. Unilateral response is due to pathology in limbs, nerve injury in brachial plexus injury like Erb's palsy, Klumpke's paralysis, bone injury due to fracture dislocation, major causes clavicle fracture. Postnatal reflexes, they appear after the baby is born. The mnemonic for postnatal reflexes is HPL. SPL, special. SPL for special. So S is for symmetric tonic neck reflex, parachute reflex, and Landau reflex. What is symmetric tonic neck reflex? Baby held from below in prone position, an extension of neck, bilateral upper arm, upper limb extension and lower limb flexion, flexion of neck, bilateral upper limb flexion and lower limb extension. So we'll remember one, that when you are extending the neck, then baby is flexing the legs, but when you are flexing the head, then baby is extending the legs. This appears by 4 to 6 months and disappears by 1 year. Parachute reflex, baby tilted towards or mimic falling. Then extension of arms, forward parachute reflex, protective extension reaction forward, appears like 7 to 8 months and it does not disappear. Landau reflex, baby held in ventral suspension in prone position, flexion of neck, bilateral lower limb flexion, extension of leg, bilateral lower limb extension. So it's like opposite to the symmetric tonic reflex, but here you are holding the baby ventrally in prone position. It appears at 3 months and disappears like around 9 months. Birth asphyxia and hypoxic ischemic encephalopathy, also known as perinatal asphyxia or perinatal depression. impaired gas exchange, hypoxia plus complication. In brain, it causes hypoxic ischemic encephalopathy, multi-organ dysfunction, and lactic acidosis due to anaerobic metabolism. Definitions of birth asphyxia. WHO definition. Failure to initiate and sustain breathing after birth is birth asphyxia. National Neonatology Forum criteria NNF is based on EBCAR score 1 minute after birth. Moderate is 4 to 6 out of 10 and severe is 0 to 3 out of 10. Essential criteria American Association of Pediatrics AAP criteria most important: profound metabolic and mixed acidosis, umbilical cord pH is less than 7, persistence of low EBCAR score 0 to 3 at 5 minutes, signs of neonatal neurological dysfunction, features of hypoxic ischemic encephalopathy, evidence of multiple organ involvement, kidney causes oliguria, liver involvement will cause increased liver enzyme. These are all the criteria for birth asphyxis. Hypoxic ischemic encephalopathy, leading cause of neonatal brain injury during, and it's worldwide. Pathogenesis: birth asphyxia causes hypoxia, which causes ischemia. Sarnat and Sarnat staging. So for HIE, you have Sarnat and Sarnat staging. It indicates clinical features and progression of HIE. It has stage 1, 2, and 3. Consciousness. Stage 1 normal or slightly irritable. Tone is normal in stage 1. Reflexes are easily elicitable in stage 1. Pupil sizes is mydriasis due to sympathetic overactivity. Convulsions are absent. EEG is normal. Outcome is 99%. Normal outcome and good outcome. That is the stage 1 of HIE. So in stage 1 you will see mydriasis, that is dilated pupil due to increased sympathetic activity, and they are slightly irritable. So that's your stage 1. Let's see stage 3. In stage 3, baby will be comatose. Tone will be fully flaccid. There will be no reflexes. There will be no reaction to light in the pupils, and the pupil size is also poor, small. Convulsions, there are absent convulsions. There are no convulsions also. And EEG will have burst suppression pattern, that is burst and then suppressed, burst and then suppressed. Outcome 50% death and 50% complication. While the in between stage 2, baby is lethargic, not comatose. Tone is hypotonia. Reflexes are sluggish. Pupil size is small, meiosis due to parasympathetic overactivity. Convulsions are largely present in stage 2. So that you have to remember, that still the brain is not like completely exhausted. Convulsions are largely present in stage 2 of HIE in Sarnat and Starnat staging. And this is shown by EEG, which is called Seizure spikes, low voltage complexes. Seizure spikes, low voltage complexes. What is the outcome here? 80% complete recovery, 20% complication. While in severe stage, where the baby is comatose and they are not even seizuring, not having seizures, then 50% death. But here, if they are having seizures, then 80% chances of recovery. Complications of HIE is cerebral palsy. So let's see what happens in term babies and what happens in preterm babies. So in preterm babies, there is a periventricular leukomalacia bilateral. Here you can see the diagram, the face, hand, trunk, leg representation, This is the zone of periventricular ischemic hemorrhage, also known as leukomalacia. Intraventricular bleed in lateral ventricular in area. So there is intraventricular bleed in lateroventricular, and then there is a zone of periventricular ischemic hemorrhage. This is known as leukomalacia, and it will cause thinning and infarction of periventricular matter, affects motor cortex of lower limb, and spastic diplegia. So this affects the motor cortex of the lower limb and spastic diplegia. Let's see what happens in term babies. So in term babies, you have your parasagittal infarction, bilateral, and it will cause spastic quadriplegia, parasagittal cerebral injury, focal ischemic necrosis, hemiplegic cerebral palsy, stroke-like condition, focal ischemic necrosis. So hemiplegic cerebral palsy, it's like a stroke-like condition. While parasagittal infarction will cause spastic bilateral quadriplegia. All four limbs are gone. Selective neuronal necrosis, for example, basal ganglia. Dystonic extrapyramidal cerebral palsy. Extrapyramidal manifestation like chorea, athetosis. So if there is selective neuronal degeneration, neuronal necrosis, like for basal ganglia, then it causes extrapyramidal manifestation like chorea, athetosis. Intellectual disability and cognitive dysfunction. Investigation. Diffusion weighted imaging, DWI, MRI, is the investigation of choice. So if you find there is an intellectual disability and a cognitive dysfunction, then your investigation of choice is DWI, MRI, diffusion weighted imaging, MRI. Management is supportive management. Maintain normal temperature, stable vitals, blood glucose level between 75 to 100, which is a neuroprotective range. Blood glucose between 75 to 100 in babies is a neuroprotective range. Treat seizures. Initial drug you need to give is phenobarbital. So if babies are having seizures, you give phenobarbital. Therapeutic induced hypothermia. Gaining popularity as an established treatment modality due to improved outcome. Mechanism is induced hypothermia will cause decreased metabolism in the brain, especially decreased free radical generations, and prevents further brain damage. Method: cooling crystals are used. Selective head cooling and whole body cooling is a better method. Temperature ranges 33.5 degrees Celsius to 34.5 degrees Celsius. This should be started within 6 hours after birth. Indication is stage 2, stage 3 of HIE who are more than 36 weeks. Termination is more than or should be less than 7 or equal to, like maximum you can do this until 72 hours after birth. Contraindication in preterm babies, if they are preterms less than 36 weeks, then it increases morbidity. So that is induced hypothermia for you. Used in stage 2, stage 3 of HIE. Neonatal seizures. Types: subtle, focal clonic, tonic, myoclonic. Myoclonic has the worst progression. Focal clonic has the best progression. Subtle is the most common neonatal seizures. Minimal manifestations in subtle seizures like blinking, rolling of eyes, chewing movement of lips. Etiology: hypoxic ischemic enchephalopathy is the most common cause. In this, seizures onset is within 24 hours. Metabolic condition like hypermagnesemia, hyponatremia, hypernatremia, rare, hypoglycemia, hypocalcemia. Most common hypocalcemia, second most common hypocalcemia. And for magnesium and for sodium, both low and high, and for magnesium high um, levels can cause seizures. Hypocalcemia and hypoglycemia and hypocalcemia is seen in diabetic mothers. Infections like neonatal sepsis and meningitis. Intracranial bleeds like subarachnoid hemorrhage, intraventricular hemorrhage due to germinal matrix bleed. Bilirubin enchephalopathy, kernicterus. Management. So you have to stabilize the baby, vitals and airway, breathing and circulation, ABCs. Identify and correct the reversible causes. If it is a hypoglycemia less than 45 mg per deciliter, you can give 2 milliliter of kg per kg of 10% dextrose followed by infusion. So IV you give 2 milliliter of per kg of 10% dextrose followed by infusion. If seizures continue, anti-epileptic medication like IV phenobarbital. If no response, IV phenytoin and levetiracetam. IV phenytoin. If phenobarbital doesn't work, then you can give phenytoin and levetiracetam. If still refractory, then you give midazolam. You can also give IM pyridoxine therapeutic trial. It will increase GABA levels. Pyridoxine, IM pyridoxine. Pyridoxine is involved in glutamate metabolism. Glutamate acid decarboxylase plus pyridoxal phosphate cofactor. So glutamic acid decarboxylase pyridoxal phosphate cofactor will increase GABA, which is an inhibitory neurotransmitter. In the next video, we'll continue with normal growth.